And thank you all for joining us today for our Orientation to Ag Worker Health webinar.
Hi, everyone. Welcome. Alexis and I will be chiming in as Lisa leads us, but we just wanted to welcome you and thank you for joining us.
Thank you, Gladys. So in order to better serve the agricultural workers and their families in our health centers, we need to better understand the migratory and seasonal agricultural worker population, as well as the Migrant Health Program. So by the end of today's session, we want you to be able to have a better understanding of how a Migrant Health Program functions and how it's funded, ag worker demographics and culture and how that impacts healthcare access, the unique challenges and barriers faced by the ag worker population, as well as services provided to the ag worker population through the Migrant Health Program. And as we begin, I'd like to share a little bit of information about our organization. We are the National Center for Farmworker Health. We're a nonprofit organization based in Buda, Texas, and our mission is to improve the health of farm worker families. And we do that by providing training, technical assistance, and resources to the national network of 174 federally qualified health centers that are funded to provide primary care services to agricultural worker families, as well as other organizations that serve the ag worker population. So in order to understand the Migrant Health Program, when and why it began, it's important to look at the history that led to the program. The United States has imported agricultural workers for a very long time. Back starting in the 1850s, due to advances in crop production, there was a demand for ag workers that increased. In World War II, from 1914 to 1918, we had labor shortages and the Immigration and Nationality Act came about. And in 1917, we had our first real guest worker program that brought 70,000 workers to the US from Mexico. And in 1942, from 1942 to 1947, we had the Bracero Act, which many of you have probably heard of, that was the largest guest worker program during World War II for contracted labor. In 1952, the H-2 program was established. It was similar to the Bracero program, but required certification of labor shortage to legally import workers. And this program is still in existence. You've probably heard of H-2A workers. They are part of that original program. So moving forward, by 1962, we had many ag workers in the fields. Conditions were harsh. They were experiencing low pay and little access to care. So President John F. Kennedy signed the Migrant Health Act, also known as Public Health Act Section 329. That authorized funds to create a small number of migrant health centers to provide preventative and primary health care services to the ag worker population. Initially, migrant health centers served only agricultural workers and therefore operated only during the agricultural season. And this created a community sentiment of preferential treatment to ag workers within the communities where the migrant health centers were located. And community members expressed dissatisfaction and demanded access to those health centers. So in response to this sentiment, the federal government made money available to health centers already receiving migrant dollars to jointly serve the community under 330 of the Public Health Services Act. This meant that health centers receiving assistance under sections 329 and 330 were under obligation to provide services to both migratory agricultural workers and the community as a whole. And although some health centers have done an excellent job in maintaining the focus of serving both populations, others have been overwhelmed and challenged to maintain the level of focus in reaching the ag worker community. This problem is further aggravated by the limited resources available to provide outreach, translation, and transportation, and other enabling services needed to serve this hard to reach ag worker population. So in 1996, Congress approved the Health Center Consolidation Act, which authorized the consolidation of Migrant 329, Community 330, and Homeless 340 sections of the Public Health Act under the umbrella of 330 programs. So under this consolidation, migrant health money was integrated into community health funding and expanded its reach to include aged and disabled farm workers, as well as family members of migratory and seasonal agricultural workers. So Section 330 of the Public Health Service Act defines the Health Center program as a funding opportunity for organizations to provide healthcare services to underserved populations. And when we talk about the definition of agriculture, we're talking about agriculture as defined in the legislation. So the term agriculture means farming in all of its branches. Basically, that involves everything from prepping the soil, seeding, planting, growing, picking, and even transporting in some cases. So farming in all of its branches is specific to migrant health, and it includes crop production, animal production, aquaculture, and those support activities involved in those industries. And then when we talk about classification of ag workers, these are the definitions of ag worker as defined by Section 330G of the Public Health Service Act. So we have three types of ag workers: migratory, whose principal employment is in agriculture. They've been employed in agriculture within the last 24 months at some point, and they have to establish a temporary home for the purposes of working in agriculture. So that means they have to travel somewhere or establish a temporary home that could be state to state in another state, or could be somewhere within the same state, but they have to establish a temporary home in order to do that work. So that's a migratory worker. A seasonal agricultural worker is their principal employment is also in agriculture, but on a seasonal basis. And they've been employed in ag as well within the last 24 months, but they do not establish a temporary home in order to work in agriculture. And then we also have aged and disabled ag workers. Again, that was added in 1996. And these are former migratory workers who are no longer able to work in agriculture due to age or disability. So when you classify those in your UDS, you would classify them as migratory, the same as you would classify them as migratory workers. So it's the two classifications you're reporting in UDS are migratory and seasonal, and aged and disabled are classified as migratory. And then we also include family members. Family members receive the same classification as the ag worker family member. So if they're a migratory worker, their family members would all be classified as migratory. And that is no matter what their age is, and if regardless of whether they have any type of insurance, because that's totally separate. We're just talking about classification for reporting purposes for UDS. And all health centers that receive 330 funds are required to report their special populations in UDS. Those that receive migrant health funding, again, are required to separate it out into migratory and seasonal. So this is important to know, especially for your staff that register patients or are responsible for classifying them and reporting in UDS, because it could affect continuation of future funding. You want to make sure you're capturing all of those patients that you're seeing that are migratory and seasonal ag workers. So I've shared just a brief overview of the classification of ag workers today. We actually have a webinar scheduled for this very same time next week that will focus specifically on classification and reporting. So it will be from 1:30 to 3 p.m. Central Time next Thursday. And we will include detailed steps for accurately identifying and reporting your ag worker population in the UDS. And we've also allocated some time at the end of the presentation to go through case studies with you, and also make sure we have a Q&A time so that we can get all your questions answered. So I do encourage you all to register for that webinar as well. So we'll look at ag worker demographics next. And the data on ag workers comes from the National Agricultural Workers Survey, or NAWS. And that's data related to demographics, employment, health characteristics. And this survey is conducted annually and is a random field survey. And the results are not published every year. So this data that I'm about to share with you is from 2015 to 2016. And the NAWS survey is available on the DOL website as a NAWS research report. So a few demographic statistics to share with you. 83% of farm workers are Hispanic, 68% are male, 32% are female, 44% are under the age of 35. And Spanish is the dominant language for 77%. And average education level is 8th grade. And of course, this information is important to keep in mind as we create our forms and health education materials for our patients, as we set up our staffing to make sure we have the appropriate language and literacy level for our patients. 57% are married, 55% have children. 33% of ag worker families had incomes below the poverty level, and 53% do not have insurance. So they may need to apply for your sliding fee scale program. They may need extra assistance with that. And 37% on average report not having a healthcare visit at all in the last 2 years. And we'll get into some more of the reasons for that in just a minute. And more on ag worker demographics. As you know, ag work is not steady. It's dependent on the season, weather, and market demands. So workers' hours have to accommodate the crops, not vice versa. Year-round work is not always available or possible due to the nature of agriculture. They have to it depends on the seasons, crop production, and even weather conditions. So on average, workers work 33 weeks of the year in agriculture and about 11 weeks unemployed in the US, and an average of 3 weeks per year outside of the US. And they're typically employed by the growers or packing firms directly. That's about 80%, with a small percent employed by labor contractors at 20%. And workers may not be employed in agriculture when they seek care at your health center, but that's why we need to make sure we know, we go through all those steps for classification, because if they've been employed in agriculture in the last 2 years, you can still classify them as an ag worker. So it's important to know all those steps. And when we talk about housing conditions, adequate, affordable, and safe housing has been and continues to be a constant struggle for migratory and seasonal ag workers. When we think about housing provided by an employer, a small 15% of ag workers may have housing provided by their employer. This is often the case for migratory workers, given that they travel for work, and it's traditionally met by growers through the establishment of labor camps. Employers do recognize the lack of housing is a serious problem, but they often face several disincentives to providing housing for migrant workers. Given construction and maintenance of these camps being expensive, especially if housing is only occupied during the short harvest season, housing is often substandard. And rental properties, most ag workers do not have housing provided by employers and often need to find their own housing. Nationally, 54% of workers report renting property for housing. However, most communities may not have enough rental units available, or they may be unavailable to farm workers because they cannot provide deposits, qualifying credit checks, or make long-term rental commitments due to the nature of their work. Therefore, ag workers struggle to find places to live, especially in rural areas where housing is already limited. Some end up sharing rental properties with others who work on the same farm to make it more affordable. However, much of the housing available for them is still deficient, crowded, and unsanitary at sometimes. So this can add to their health risks. Crowded housing also makes it difficult to practice social distancing recommendations. Another housing condition is private housing. Some farm workers have their own private housing. This is often the case for seasonal ag workers. Private housing is not subject to federal regulation, though, so what's available to ag workers tends to be, again, sometimes substandard and many times expensive. So we often see workers living together under these conditions as well, especially with family and other relatives. Again, this makes it difficult to quarantine and practice social distance, physical distancing recommendations, especially in these times of COVID. We do have some ag workers, 33%, that report living in crowded shelters. And in the absence of housing, farm workers may be forced to sleep in tents, cars, ditches, or even open fields. The migrant labor force is important to the agricultural sector, which in turn is an important part of the overall local economy. It's clear that steps should be taken to help migrant farm workers find solutions to their housing needs. As mentioned in the previous slide, much of the housing available to ag workers is deficient, crowded, and unsanitary, so this adds to their health risks. Some common illnesses related to housing that we often see are UTI and intestinal parasites, skin conditions, respiratory conditions, and other infectious diseases. And again, crowded housing makes it difficult to practice social distancing recommendations. So there's an increase for flu, COVID-19, and other illnesses. And when we talk about working conditions of ag workers, the availability of work depends on the season, weather, and market demands. So there's likely a fluctuation in employment. Hours may be extended. They may work early morning to early evening. They may be working 7 days a week versus a normal 5-day work week. Some work in the fields. Most are employed by growers, about 80%. And income can be paid by the hour, by piece rate, and some are even on paid by salary. So that varies. And the majority do not receive sick leave, retirement, unemployment insurance, vacation pay, all those benefits that we get to enjoy. And 86% of farm worker households had not received a benefit of a needs-based program such as WIC or food stamps in the past 2 years. So the majority do not receive benefits. And when we talk about migratory and seasonal ag workers, the migration trends, there are three main migration trends that we focus on. There is a restricted circuit, and those are farm workers that follow crops in one area. So they're centered around a home base. They move to work, but they come home frequently. This is usually your seasonal ag workers. 81% are settled in one area. They work within 75 miles from home. There's less transborder crossing and more workers engaged in other industries during the off season. For example, they may work in construction during the off season or something like that. And then we have point to point, where farm workers move away from home base for an extended period of time. These farm workers often go back to the same location for multiple years, and they often travel with their whole family. And these are considered usually your migratory workers, and the number has decreased significantly. It's now about 19%, but we do want to make a note that this statistic is based on the NAS data, which excludes H-2A workers. And H-2A workers are migratory and account for about 10 to 15% of the ag worker workforce nationally. So that number may not be quite accurate. And an example of this is a family, for example, living along the Texas-Mexico border in the Rio Grande Valley that travels to Michigan every year. And they have that same pattern they go to every year. The last category is the nomadic, and that includes farm workers that travel to wherever there is work. They usually don't know when or where they'll move next, and they're generally foreign-born, young single men. And there has been an increase in H-2A workers and males traveling alone. And there are many occupational risks that ag workers encounter. Of course, agriculture is consistently ranked as one of the 3 most dangerous occupations in the nation. In 2018, 411 agricultural workers died of work-related injuries. And then immigrant workers are often vulnerable to labor trafficking, where an employer may control the movement of their work through threats, physical abuse, debt bondage, or other means. Agriculture actually had the second highest number of reported labor trafficking cases in the US in 2015. And then we also have an increase for illness and health conditions, given they're considered essential workers, especially during this COVID pandemic. And many of the occupational injuries that workers face are related to the specific type of work they do. This could include musculoskeletal injuries and disorders such as carpal tunnel syndrome, shoulder impingement, sprains and strains, lower back disorders, that sort of thing. When we talk about risk to repetitive motion and heavy lifting can cause pain, arthritis, and other health problems. Motions that ag workers do that can contribute to these ailments include stooping, picking, carrying. They're doing a lot of lifting, reaching for things repetitively. and even climbing ladders. That's a risk for fall. Other risks are related to the way ag work is set up in general. So ag workers are outside, so that plays, so the weather plays a role and can contribute to heat stress and dehydration. They're also at risk of insect, rodent, and snake bites. And as I mentioned earlier, some are paid in a piece rate versus hourly wages, and that encourages people to work longer, harder, and faster without breaks in order to earn more. Beyond the expected physical impact, that practice contributes to workers not taking the time to take care of themselves while they're working. So not going to medical appointments, lack of management of chronic health conditions. So those are all related to occupational risks. And then injuries to workers may be caused by the use of machinery and tools. So they're working with tractors, they're working in silos, so they're more likely to have lacerations and crush injuries, that sort of thing. Lots of traumatic injuries, especially being crushed by the large equipment. And then vehicle accidents are also a problem. Workers are often transported to and from work by their crew leaders in unsafe vehicles. They may not have seat belts, or they may be overcrowded. Also, because they migrate, they're on the road more, so the opportunity for accidents on the road is greater for ag workers than it is for the general population. And then on lack of safety precautions, not having, especially now during our situation now with COVID, not being able to maintain a 6-foot distance, lack of personal protective equipment, limited hand washing stations, being unable to quarantine if they're ill. Those are all due to their living conditions, but they are an occupational risk. And then this slide highlights some of the problems associated with field sanitation, pesticide exposure, and other environmental risks associated with agricultural work. So again, agricultural work often requires stoop labor, climbing, carrying heavy loads, and direct contact with plants. And the direct contact with plants puts them at risk for exposure to pesticides and chemical fertilizers that are used in cultivating the plants. So some plants, such as tobacco and strawberries, release chemicals that are toxic to humans or that can cause severe allergic reactions, such as contact dermatitis. In addition, there are anecdotal reports of workers resorting to irrigation ditches and runoff ponds when safe water is not available for drinking and washing. So pesticides, chemical fertilizers, and organic waste contaminate that water, and that can lead to illnesses including conjunctivitis, intestinal illness, cancer, infertility, birth defects, developmental delays, and neurological disorders. And these disorders can often be misdiagnosed given the common symptoms that they have. So that's why it's important to know that you're working with an agricultural worker so that you can evaluate them properly. And the EPA does estimate that 10,000 to 20,000 poisoned ag workers per year. And that's per the Farmworker Justice site. And pesticide exposure via labor tasks, residue on clothes, shoes, and skin can expose the family as well. Because when they come home with all those chemicals on their clothes and shoes, they're exposing the rest of their family members as well. And then, of course, drinking and bathing in this water exposes workers to potentially harmful chemicals and also waterborne parasites. And then when we talk about sanitation and hygiene issues, and availability of safe drinking water is a problem. Lack of nearby toilets and lack of nearby hand washing facilities are also issues and risks. So to address some of the occupational risks, the Occupational Health and Safety Administration, or OSHA, has put regulations in place that require agricultural employers of 11 or more workers to provide drinking water, hand washing facilities, and toilets for their employees. However, farms with 10 or fewer employees are exempt from these requirements. And the intent of this exemption was to avoid placing an undue financial burden on small farms However, as a result, these very basic amenities are not required by law for many farm workers, regardless of the conditions or hours that are required of them for working in the fields. So there are three regulations specific to ag workers. The Department of Labor has put in place the Migrant and Seasonal Agricultural Worker Protection Act, and that was in 1983. And that established the right of farm workers and as well as the guidelines labor contractors must follow. And then in 1987, OSHA put in place the Field Sanitation Standard. This applies in all states and requires availability of potable water and sanitary toilet facilities. And then the Environmental Protection Agency put in place the Worker Protection Standard in 1992. And this is a federal regulation designed to reduce pesticide poisoning by requiring safety training, notification of pesticide applications, use of personal protective equipment, restricted entry intervals after pesticide application, decontamination supplies, and emergency medical assistance. So it's important to remember that enforcement is dependent on the size of the farm and the entity in charge of enforcement in that area. And there are some exclusions, occupational health and safety exclusions. Farm workers are excluded from the following labor rights. They do not have the right to organize and bargain collectively under the National Labor Relations Act. They are not entitled to overtime pay under the Fair Labor Standards Act, with the exception of California. They are only covered by 7 Occupational Safety and Health Administration standards. So there have been some improvements in some states. For example, as I mentioned in California, Governor Brown introduced a bill in 2016 that will expand when farm workers are entitled to better overtime pay. And this is the first and only state in the nation to grant overtime to farm workers. And he also signed a landmark agreement that gave farm workers the right to organize. However, that's not the case in many other states. This means that farm workers have less protection than most other labor groups and are at a greater risk for illegal and unfair treatment. They're also at a risk for injuries and unhealthy conditions, scams, and many other risks. So research indicates that agricultural workers have lower rates of many chronic diseases compared to the general population, but a lack of access to health care may mean that many have undiagnosed health conditions. Common chronic illnesses include diabetes, obesity, hypertension, chronic respiratory musculoskeletal disorders, just to name a few. And the primary challenge for an ag worker patient with a chronic disease, especially one who migrates, is continuity of care and self-care management. And then, of course, mental health is also a concern among agricultural workers. Factors that impact mental health include anxiety. They include the fact that they're traveling alone. They're separated from family for long periods of time, so they lack that family support. Lack of adequate childcare is a stressor. Lack of adequate education and nutrition programs for children. Food insecurity. And then, of course, now in light of COVID, food banks have experienced an increase in clients requesting resources. So, and Gladys, I think you might be able to speak to this. Agricultural workers may also be reluctant to talk about mental health issues due to cultural barriers and stigma.
Yes, and we've seen an actual increase in the need for mental health care, especially now in light of COVID. But these are just a few conditions that we often come in contact with agricultural workers in particular, and they include anxiety, depression, substance use, domestic violence, and PTSD. But again, these conditions are often experienced because of some of the stressors that Lisa already mentioned. But mental health continues to be of great priority to health centers across the country, especially now.
And thank you, Gladys. And this slide talks about the barriers that ag workers face related to accessing care. Mobility and long days often threaten ag worker health and pose a significant barrier to accessing care. And as previously noted, many agricultural workers have total family incomes below the federal poverty level. So this puts a worker in the predicament of having to choose between paying for health care and meeting their essential needs. So many workers do not have health insurance, which forces them to seek medical care only when it's absolutely necessary. And preventive care may not be a priority. And then because of the limited benefits that workers receive, sick leave is rarely an option. So workers do not take time off from work to take care of their health for fear of losing their jobs. And one of the most commonly reported barriers is language. An estimated 74% of workers cited Spanish as their native language, and therefore their inability to speak English fluently or comfortably can pose a great barrier to their health care. And many workers have low levels of literacy even in Spanish, even in their native language. Also, the culture of the workers often gets into the way of accessing medical care. For example, workers may rely on homeopathic remedies handed down from generation to generation to treat ailments, and therefore put off seeking medical care until it's often too late. And workers are often unfamiliar with the U.S. healthcare system and therefore do not seek existing services or have the knowledge to navigate the healthcare system effectively in order to meet their needs. And lack of transportation, especially in rural areas without a mass transit system, is also an issue. Due to the quarantine and reduction in staff, there are minimal transportation services available from health centers at this time. Those are all individual level barriers to care.
One other one is also listed there, Lisa, and I think is definitely something to highlight right now in times of COVID, as a number of different health centers across the country transition to virtual platforms. There's a lack of access to technology and limited digital literacy. So I know here at NCFH, we're looking at ways to be able to bridge that gap and be able to provide maybe even telehealth services to ag workers and other vulnerable populations better.
Thank you, Gladys. And at a systems level, we have labor policies that include lack of sick time off, paid sick time off. Those are barriers to care since they don't have that available to them. Community and workplace barriers, limited healthcare sites, immigration systems and threat of deportation, exclusion from public and private health insurance programs, and then lack of awareness about challenges faced by ag workers among public health officials and healthcare providers. Those are all systems level barriers to care.
And I think that's also a big reason why we at NCFH continue to really talk about agricultural workers and why there is a significant need for them to be able to access quality healthcare. It's definitely a part of our mission in terms of what we do. But imagine being in a new environment and like we mentioned already, not being familiar with the system and not knowing how to navigate it. That can definitely be a barrier in you being able to just get the treatment that you need for any type of health condition.
So now we'll take a look at the required services available through the Migrant Health Program, as well as some challenges. So grantees receive federal funding from PHS Section 330 to provide services for people in the community, and 330G specifically for the migratory and seasonal ag worker population. And although the size and extent of the services varies by center, the majority of health centers do provide comprehensive care within their networks, although it's not uncommon to have health centers offer the basic on-site services and then refer out to a larger clinic within their network for additional services. And as a general rule, the larger the budget, the more comprehensive services a health center can offer. But at a minimum, these are the wide range of diagnostic and support services the federal government requires. So primary care, preventive, emergency, and pharmacy services. Primary care includes treatment of infections, chronic disease, injuries, accidents, and general health problems. Preventive care would include immunizations, health screenings, etc. Emergency includes accidents, injuries, sudden illness. And then for pharmacy, on-location pharmacy services. And outreach and enabling services are important. In fact, they're critical, especially for the migratory and seasonal ag worker population. They help increase access to care for this population. So as we discussed earlier, ag workers face many challenges in accessing primary health care services due to the hours they work, the lack of transportation, etc. So these are services that health centers can provide to help ensure ag worker families have access to primary health care services and facilitate access to comprehensive health and social services. And services include, but are not limited to, those listed on this slide. So outreach, eligibility assistance, transportation, interpretation and translation, patient and community education, coordination of care, and case management. So when we talk about addressing service delivery challenges, a couple of them relate to the culture and language. So if we think about it, meeting culturally and linguistically appropriate services or class standards, provision of multilingual services, for example, reception, health education, patient education, prescription instructions, health center promotional information, medical visit information, making sure that's in the appropriate language. Recruitment and retention of qualified bilingual and bicultural staff is also a challenge. And then at the operations level, oftentimes demand exceeds capacity. That can lead to, for example, long wait times in your health center, hours of operation, and then making sure that you have relevant training and continuing education for your staff. Those can all be challenges. So in order to address service delivery challenges, we need to take a look at those systems within our organization. So we can make sure that we pay attention to the needs of the population and ensure services are accessible. So we need to look at our policies, procedures, and training protocols to make sure that we have those in place. So when we're looking at that, we can ask some questions like, how do we provide culturally competent care at all levels of our organization? How can we let patients know that interpretation services are available to them? Are we providing information at the appropriate literacy level in both English and Spanish, or whatever language is the dominant language of your farm worker population in your service area? How can we learn about our patients' healthcare beliefs? Are there ways of addressing that so that this doesn't become a barrier? So really getting to know your population is important. And other system barriers that need to be explored include, are we providing extended hours, such as weekend hours, or taking services to where ag workers are? I know a lot of health centers do provide late clinic hours, especially during the growing season. And then also many have mobile units that they're taking out to the farm workers to make sure they're getting the services they need. Is there more that we can do to provide transportation and access? And how do we equip our staff and outreach workers to provide information to the community about accessing care to our health center? How are you promoting your health center and letting your farm worker population know that you're there to provide services for them? And those are just a few things to consider in addressing service delivery challenges. Continuity of care is one of the biggest challenges in ensuring quality health care for ag workers, mainly because of the mobility of the ag worker population. So even when an ag worker returns to the same area year after year, continuity of care, managing those conditions is difficult. Changes in geographic location may occur multiple times a year, as we mentioned, based on those mobility patterns, which disrupts chronic disease management for conditions like diabetes and other things. And what we often see is agricultural workers only seeking care when absolutely necessary, or they may begin treatment but can't continue because it's time to move again. Or even when they seek care in a new community, they may not remember the names of the medications they were prescribed or the dosages because they don't have their medical records with them. All of these things come into play, and we need to think of ways that we can help with that, to help with that continuity of care. And one of the things we can consider that's really important is case management. We do know that proper case management can help prevent the disruption of chronic disease management and can prevent misdiagnoses that may occur at the new location, and even reduce the chance of a patient over medicating, making sure that they have that their case manager is sharing that information with them and making sure they understand. Self-management is the key to controlling chronic illnesses. So it's important to educate our patients in order to help them understand what they need to do to manage their illness and what information and records they need to take with them when they travel. So we need to help set the stage for the best possible outcomes. So now we've shared information about the ag worker population with you, and now I'd like to share some resources and information with you that might be helpful. First of all, I'd like to tell you about the Ag Worker Access Campaign. Hopefully you're all familiar with it, but the Ag Worker Access Campaign is a national initiative to increase the number of migratory and seasonal agricultural workers and their families that are served in our community and migrant health centers. It was launched in 2015 as a joint effort by our organization, NCFH, alongside the National Association of Community Health Centers, NAC. The goal of the campaign was to reach 2 million ag workers and their families served in community and migrant health centers. And since the campaign's launch, we've been able to maintain an increase in the number of ag workers served every year. And according to our 2019 UDS reports, we've actually surpassed our halfway milestone of 1 million ag workers served. So in 2019, community and migrant health centers served 1,031,049 agricultural workers and their family members. So that's a 14% increase since 2015, and that's awesome. And that's due to the great work that you all, the health center staff and advocates, are doing every day. So we need to keep moving forward and reach our goal and surpass it, and we need your help to do that. So I do encourage you all to visit our website at ncfh.org and sign up to join the campaign today and access the tools and resources that can help you in increasing access to care for your ag worker population. And look forward to having you be a part of this initiative. Another resource that we have available at NCFH is our Increased Access to Care for Ag Workers program. We call it our IAC program. And our IAC program and associated training opportunities were launched in collaboration with the Ag Worker Access Campaign back in 2015 to assist community and migrant health center staff in accurately identifying and reporting their ag worker patients in the UDS. And since then, the program has grown to include a national virtual network comprised of health centers, health center controlled networks, and primary care associations working together toward the mutual goal of increasing access to care for ag workers and their families. So through this program, consisting of training, learning collaborative activities, and ongoing support, NCFH has been able to help health centers modify their current systems and processes to demonstrate their effectiveness. And as a result, participating health center patient registration teams are implementing the steps necessary to identify and accurately report the ag worker, their ag worker patients in UDS. They're also participating in migrant health action planning to set goals for and setting concrete steps to reaching those goals to increase their numbers. And as a result, IAC members have seen a higher number of ag worker patients served when compared to non-members. So 31% versus 2% since 2013. And we do have 2 learning collaboratives that are associated with this program. We have IAC Core, which focuses on the basic principles of proper identification of ag workers and the goal setting and getting to that, getting all your systems in place for that. And then IAC Plus it goes beyond that to focus on addressing SDOH factors in order to increase access to care. So both learning collaboratives together are great resources for you in order to increase your access to care for ag worker population. And then I do want to share that also part of, for those folks that are part of our Increased Access to Care program, they are able to self-nominate for our Promising Practices Award. And that is an award that is given out annually to a health center that has shared, that has increased their numbers and has come up with an out-of-the-box type of idea on how they're going to do that. So this year's Promising Practices Award winner is Ampla Health, based in Yuba City, California. And what they did was they integrated their Migrant Health Action Planning, their Migrant Health Action Plan, into their organization-wide strategic plan. So they have a specific strategic direction that's specific to special populations. And they've had, that's been successful for them. And they were able to get buy-in from all levels of the organization and get everyone involved in that commitment to increasing access to care for ag workers. So we do congratulate Ampla Health, and we look forward to sharing their promising practice in upcoming events where they can let folks know how they went about doing that. And the funding for our Increased Access to Care Award, as well as our Migrant Health Scholarships, our NCFH scholarships, is funded through our Commemorative Artwork series. NCFH does commission an artist every year to create an original image for the artwork series, and then sales of the artwork go toward scholarships and the IAC Promising Practices Award. So we do encourage you to visit our Commemorative Artwork series webpage as well, and see all the beautiful images that portray the ag worker population. And you can also purchase note cards and artwork prints there. And then our NCFH website, we do, if you haven't visited our website, we do encourage you to visit it frequently. We are updating it with information constantly. We do have some great information for you there. We have population estimates. We have lists of migrant health centers. Webinars are archived and available to play on demand there. We have lots of tools and templates for you related to ag worker registration, policies and procedures, just a ton of great information that we encourage you to access. And one of the specific pages that I'd like to highlight is our ag worker fact sheets. Our ag worker fact sheets provide detailed information on specific aspects of ag worker health and are updated every 2 to 3 years. And we have actually have a fact sheet specific to ag workers and COVID-19 that's updated monthly. So we do encourage you to access that site and get more information about the ag worker population. It's a great wealth of information. And then we also have our population estimation maps, another great resource. This map displays the 2017 estimates of crop and animal production workers. And you can go on the map, and all these colored dots you see, you can hover over them and see the number of directly hired and contracted workers by county. So you could go to your the counties that you serve or that you're considering serving and see how many ag workers are estimated for that area. These numbers are threshold numbers only and could be affected by current weather conditions, labor policies, et cetera, but it is a great starting point. And there again, you can access them on the NCFH website. We also have a webpage of ag worker specific resources related to COVID-19. This includes links related to COVID-19 that are, we have resources in Spanish and also other indigenous languages. So a lot of great information there. We also have live information from CDC that's constantly updated there. So it's a great resource. And then these are the National Training and Technical Assistance Partners. That offer training and resources to health centers serving ag worker populations. NCFH is one of them. We do encourage you to visit all 6 of the NTTAPS sites. They're valuable. They offer valuable resources for ag worker specific training and technical assistance. And we encourage you to visit their sites and utilize their services. And this is our contact information. Again, I'm Lisa Miller. My colleagues Gladys Carrillo and Alexis Leboy We'll be continuing on with our discussion following this next slide. And we also have references available for you for all of the statistics that we shared.